Okay, good morning, everyone. We might as well get the show on the road, as they say. I'm Dr. John Stoltz. I'm a professor of biology and now also in the Department of Civil and Environmental Engineering and Science at Duquesne University. I'd like to welcome you all. We have a great program for today. We have most of our participants will be in person, but we do have some virtual participants as well who will be presenting. So thanks right off the bat to our AV folks because today it's going to be absolutely critical. But welcome to Duquesne University. The university's mission has always been to serve the underserved and provide an opportunity for education. We're here today to learn both in person and virtually about the impacts the development of unconventional oil and gas has on people and communities. While the focus may be on Pennsylvania, the implications are far-reaching as more than 30 states currently have oil and gas drilling. 15 years ago, the League of Women Voters realized that there was a need for a public forum in which scientists, clinicians, and public health advocates could come together to present their findings. They have been joined by the Physicians for Social Responsibility of Pennsylvania and Halt the Harm. This year's theme is Our Work, Our Health, Building a Future Beyond Sacrifice. It comes at a time when our regulatory framework is being dismantled and the value of human life is being minimized for the sake of monetary gain. Fortunately, communities are responding, demanding responsible development, whether this requires larger setbacks for oil and gas structures or greater attention to the health studies. They are no longer, I should say, we are no longer silent. So it is with this in mind today that we have sessions on childhood cancers and health studies, exposing resources of industry-related health issues, public dialogue through media, oil and gas policy, community organizing, and creative protesting. Our keynotes feature the filmmaker who directed Midnight Oil and a community organizer whose organization helped relight a community. I would like to thank the League of Women Voters, the Physicians for Social Responsibility Pennsylvania, and Halt the Harm for their help in putting on this program. Thank you, Tanya, Deb, and Ryan especially. Thanks to the Heinz Endowments for their support, without which this conference would not have happened. I would also like to thank Duquesne University for providing such a nice venue and technical assistance, and the School of Science and Engineering and the Department of Civil and Environmental Engineering and Science. Special thanks go out to Anita, our administrative assistant, who has set up all the food and other things. And of course, there's refreshments at the end of the conference. Some housekeeping notes. The restrooms are in the Shepperson Suite, which is out there. We ask the speakers to be respectful of their time allotment. There will be time warnings, and so watch for the signs. And for the Q&A, we ask attendees to write your questions using the index cards and pens at the tables. We'll have people picking them up shortly before the end of each presentation. I look forward to the presentations and panels and some healthy discussion. And now I hand over the podium to Tanya Verkaitis for additional remarks. Thank you.
Well, John said it all, so I'm done here. Good morning, I'm Tanya Verkaitis. Thank you for being here with us today. And thank you to all of our amazing speakers for joining us to share their expertise and knowledge. If we could give them a round of applause for appreciation. Last year, with the theme of New Directions, we celebrated the first year of partnership with the League of Women Voters, Dr. Stoltz, and PSRPA. This year, our work, our health, we focus on the collective. Those of us who do this work and its impact on our health, physical, mental, emotional, the work of the communities that we work in, and the impacts of industry and waste on their health. And many of us doing this work live in these communities that we serve. And then there's the impact to our collective health through the violence of an administration who forcefully suppresses people and laws that are meant to protect people and our planet. This conference is in defiance of that. It celebrates the actions each of us takes every day to build a better future. We have a role to play, and no part is too small. The only wrong role is apathy and silence. So let's make some noise, y'all, for resilience, resistance, and radical love. We make a difference daily. Thank you. And I'll invite our first panel up. That would be Lauren Minsky, Kathy Nolan, Dani Wilson, and Alison Steele. Thank you.
Good morning, everyone. I want to start by thanking Duquesne University, League of Women Voters, Physicians for Social Responsibility Pennsylvania, and again, our fantastic slate of speakers throughout the day, but this first one in particular, to which I am partial, and also to everyone who is with us here today and online. My name is Alison Steele. I am the Executive Director of the Environmental Health Project. We are a nonprofit, nonpartisan public health organization that works to limit and prevent environmental exposures from shale gas development. EHP was one of the first organizations that stepped in to gather information about the impacts on frontline residents at the beginning of the fracking boom. And we worked to consolidate the limited but growing information available at the time in order to answer the difficult questions we received from frontline residents. Questions like, what was happening to them? Why were they getting sick? Should they move? In the years since then, we have watched the mounting research illustrate a clearer and clearer picture of the relationship between exposures to shale gas pollution and adverse health outcomes, including respiratory, cardiovascular, neurological, and reproductive impacts, and cancers, which is what we'll be talking about on this first panel today. Everyone in this room understands the value of research and the role that it plays in our respective lines of work, especially when it can be applied to reduce or prevent health harms. Whether it's members of the media helping to shift public opinion, policymakers striving to enact better health protections for their constituents, frontline residents organizing to defend their communities, or clinicians working to provide better care for their patients, we all rely on that same foundation for our work, what the science tells us. And what the science tells us is that there is an undeniable connection between pollution exposure from shale gas development and adverse health outcomes. And it's not a spoiler because we're going to be talking about it through the whole panel. We know enough to take action. So in this hour, you'll hear about trends in research, tools for understanding that data, and networks for leveraging that knowledge. In essence, a showcase of what we know and what we can do with it. So to start us off, I'm going to introduce Kathy Nolan, MD, Senior Research Director at Catskill Mountain Keeper and co-founder of Concerned Health Professionals of New York. She has a medical degree and a Master's of Studies in Law. She has specialized in pediatrics, clinical research design, and bioethics, and we are thrilled to have her with us today to talk about her work. Kathy?
Thank you, and good morning, everybody. For myself, people would ask, what are you going to do to make shale gas and public health sexy? And the answer is get a cold last week and then have allergies. So that's my voice today is not my usual voice, but I hope it'll carry the message and we can do some good work here together. So I want to talk about how we connect the dots on information about the impacts of shale gas. And talk about the causal role of shale gas and oil in human illness. And I have at the top of this slide my case that I'm going to make that fracking for shale gas and its storage, transport, and use harms all human tissue and organ systems. But since you're maybe coming in at different levels, you can raise it as a question. Do these activities cause adverse human health impacts? And see whether or not I am able to make the case here for this. Now, there are many different ways to think about causality, and so I think it's helpful to lay them out here. People will talk about something being a necessary cause, so you have this only if you have that. You have to have this in order to have that. There's a sufficient cause. If you have this, then you will have that. An approximate cause. This, and then that comes immediately. So the cause that's right before something. This is kind of logic and philosophy, if you will. Final cause is the intentional cause. Why do we have this and that? And unfortunately, I think, most of what we're dealing with in oil and gas conversations are multiple causes or multifactorial causality. We don't have simple, necessary, and sufficient causes in most cases, although we do have in some, I believe. So how do you assess or prove causality? Well, it depends upon which type of causal reasoning you're talking about. Necessary causes depend on empirical data, as do sufficient causes and proximate causes. Final causes we're going to leave aside for today. That's philosophical or theological, maybe social, so we might get to that at some point. And multiple causes is a special type of reasoning that I think is really important for human beings, which is inductive reasoning. We take data, we take systems, we take probabilities, and we form a judgment. Basically, we form an opinion about something. And then we can try to justify that and share it with others. Now, when we talk causality, you may think pretty quickly about TV shows on Law and Order. There's criminal culpability, where something is said to be known beyond a reasonable doubt, or there's a preponderance of evidence that's how certain we are that something caused something, that a person committed a crime. And there's similar levels, but less rigorous for civil responsibility in the tort law system, where you generally have a weighing of evidence by judges and juries. Social policies are more variable than those standards and tend to be, in some cases, less rigorous and other cases more rigorous. So you can have complete lack of oversight, which I think has happened in dealing with oil and gas technology, to some countries and systems where they use the precautionary principle. If you believe there might be a harm, avoid it. Don't go that route. And especially in the United States, a lot that's in between. I came to thinking about causality this way because of clinical thinking. How do we make a recommendation for a person that we think has a diagnosis for a treatment that we think will cause them to get better? So we think we understand the causes of how they became ill. We think we can help to change that. And I think that a similar sort of reasoning can apply when we're dealing with social situations. In the clinical realm, we respect individual choices quite a bit. As a person gets to determine for themselves what level of risk and what level of certainty about the causalities that are involved that they are willing to go with. And again, similarly, I think communities have a role to play in terms of letting people know how much risk they're willing to take on and when they're going to really fight back. This is a busy slide, I see. There's a bunch of stuff that goes into thinking about things when you're talking about multifactorial causality. start with in oil and gas, we start with the chemistry, the toxicology, the geology, the routes of exposure, the pathophysiology, the epidemiology, and the response to interventions. So dose response curves, if more of an exposure gives you more illness or worse illness, then that suggests causality in a stronger way than if you don't see a dose response curves. And most importantly for me, looking at shale gas exposures, particularly in Pennsylvania, I'm coming in from New York where we banned fracking before it ever got in. But in looking at situations in Pennsylvania, I have seen individuals and families who have gotten better, their health impacts, when they moved away from their exposure. So that is a causal factor that we can now use to say that what they were being exposed to was causing their illness. In terms of probabilities, you have this complex mix that we'll be talking about throughout the day. And it involves looking within a pattern and recognizing, as I said, connecting the dots and forming a judgment. When the evidence is strong enough, I think you can do that, and you can convince others that they should honor that. We started out in the history of shale gas talking about just case histories. People would get sick. People out west, where fracking started first, were getting sick. And we knew the toxicology, we knew the chemistry, we knew they were being exposed, but it was just case histories. This was 10, 15, 20 years ago. Then we went to anecdotal evidence, where you've got multiple people in the same community getting sick. And then you have a series where you have a whole bunch of people getting sick. And when the numbers get big enough, you can do a case control study. We can't, in shale gas work, generally do randomized studies. You can't expose somebody on purpose and not expose somebody else. But you can take situations in which that happens naturally, either from history, where one group was unexposed and then gets exposed and then may get unexposed again, or by comparing two very similar groups of people, the only difference being whether or not they have the exposure. Some randomized, almost completely randomized studies came with farm animals in New York and Pennsylvania early on, where farm animals exposed to one water source that had contamination with fracking got very ill and had reproductive impacts and so forth. And unexposed farm animals did not have that. And I think there's something close to a randomized study in the timelines within Pennsylvania and in studies that are now available to do and have started to be accomplished between what's happened in New York and what happened in Pennsylvania. My claim generally is that I've been able to find evidence of fracking's harm in every system of the body. We're going to focus in this panel on cancer, but I wanted you to see that the evidence is accumulated, and if you have a particular interest in another area, that there's ways you can get information about that particular organ system. And I also wanted to share this graphic, this image of both male and female anatomy. It's an open source image, but includes both genders who don't necessarily respond the same to these exposures. So again, a busy slide. This is the slide pulling out from the literature representative research that shows the impact of oil and gas extraction, transport, storage, and use in humans. And particularly, this is shown up in regard to leukemias and lymphomas. The last entry here, these are all entries from the compendium of scientific and medical evidence on the risks and harms of fracking. I'll show a link to that at the end. This is what you get if you go in and you search leukemia or you search cancer. You can pull up research that has been collected on this. And the last entry is not in the compendium because it wasn't about fracking, but I've included it. It was from 2013, and there were other studies coming out that oil and gas workers who were adults were developing cancer if they were on the oil platforms in the North Sea. So they're being exposed primarily to benzene, but other chemicals that are carcinogenic, and they got cancers. So we should not be surprised when people are exposed to oil and gas through the fracking process, which leaks things like benzene, and that we are able to document that those exposed individuals also form those same kind of cancers. It's particularly true in children. This is very, very worrisome because these types of cancers take a long time to develop, and yet we're already seeing them. So this is fairly intense exposure to generate this kind of impact. These studies basically show that the closer you are to a fracking site, the more likely you are to develop cancer. And the closeness is, as the first entry here, Clark et al. From 2022, showed that they had increased levels of leukemia in children who were as much as 10 kilometers. That's 6.2 miles from a fracking site. So today's talk is not about routes of exposure, but exposure generally can be via air and also via waterways as the underground explosions create pathways. It can also be from just waste that's dumped into our environment. In many of the situations that are documented in these, in this research, there are multiple paths of exposure. So I included this slide because of the first entry there, heart attack and heart failure with Tricky in 2023. This is a study I mentioned before where they looked at the counties along the southern edge of New York State and the counties along the northern edge of Pennsylvania, not the ones that were right next to each other because they thought there might be some, it might be hard to tease out the data, but basically stratified counties that were unexposed because of the regulations in New York State and exposed very heavily in Pennsylvania. And rates of heart attack and heart failure went up greatly. They went up in Pennsylvania, and they stayed stable and even maybe got a little better in New York over time. So this is a case control study that's very close to the design of a randomized trial. And we should be repeating it for other sorts of outcomes that we find to be of concern. So I don't want to give you all this information and not say that there are things we can do. At the individual level, we can avoid exposures even if we're in an area where this activity is going on by watching local air quality and water quality and closing windows, running very high quality HVAC systems or air purifiers. HEPA level filtration will remove a lot of the particulate matter that will carry these toxins into the environment. You can drink bottled water, use a reverse osmosis system, and test radon levels and maybe make some accommodations. And in extreme situations, relocate. When I get to the point as a clinician telling somebody they have to move in order not to be sick, that tells me that the society is sick. We should not have environments in which people cannot live. So when I found myself telling people that that was the best way for them to help themselves or their children, that motivated me to do this work and bring this message to us all. So we can change things. We can use law and policy to minimize or eliminate exposures, regulate emissions, spills, planned releases, increase setbacks. I came to believe very quickly on in my work that that was not enough, that those simply changing the system by making this, tinkering around the edges was not sufficient. So I have worked in New York and around the country, in North and South America and a little bit in Europe, to ban fracking. I think it is the way to prevent people from being made ill by it. And if we have to start with reining in the infrastructure first, then we start there. Both the infrastructure and the activity itself carry these harms for the people who live nearby. And they go pretty far out from the place where they're done. So I'm going to stop there. And this is a link to the compendium. If you search for that online, it'll come up, Compendium Oil, Gas, Health. And as I say, you can, for any particular subject matter that you have, it's a searchable database, and it now collects over 2,000 individual pieces of research that show these harms and go into some detail about how they've been documented. Thank you.
Thank you so much, Kathy. We are going to have follow-up questions at a Q&A segment at the end. So be sure, if you've got questions from Kathy's presentation, write them on your note cards and we'll get them up front. But in the meantime, I'd like to introduce our next presenter, Lauren Minsky, PhD. She's a faculty member of the Health Studies program at Haverford College. Her research looks at historical trajectories of environmental health, and today she'll be talking about a tool she created to visualize cancer incidence signals over time. And we are excited to hear more about that, so I'll hand it off to Lauren.
My name is Lauren Minsky, and I really appreciate the invitation to come today and to share some research that I've been doing with a team of students at Haverford College. And we've been basically, as Kathy was talking about, this idea of trying to connect the dots and form a judgment. We've been trying to do that with cancer and communities' experiences of cancer at a local level. So, as Kathy gave us a nice review of, we have a lot of abundant gold standard scientific studies that very clearly show us the impacts of shale gas extraction and processing and transport, but also the oil and gas industry more broadly on a wide variety of human health systems, and certainly in terms of the incidence of cancer and cancer in children. We also have, I want to highlight really important journalistic accounts. My own introduction to Washington County came through authors like Eliza Griswold, the work of David Templeton on cancer clusters, Justin Noble's important work on how the radioactive secret of the oil and gas industry. I'm probably, also Bilal Modley back in Delaware County, where I'm from, sort of documenting with films. So we know there's a lot of human health harms, and I think they've played an important role also in sort of collating and giving wider public exposure to the abundant experiential evidence that residents have, and residents regularly testify to, based on their own lived experience, that they have a lot of cancer and a lot of pediatric cancers, and often a lot of rare pediatric cancers in their communities. Oh, sorry, let me just quickly go back. So we have, however, the ongoing challenge, as will surprise no one, of the kind of ongoing merchants of doubt for the fossil fuel industry, the constant refrain that you can't be sure that that's actually happening in your community, or efforts to deny that the fracking wells in a particular town or the oil refinery actually has any connection to elevated rates of cancer in the communities around it. And indeed, one of the things I came to appreciate through meetings with community organizations in Delaware County, where I'm from, is that there really is actually an absence of quantitative data about communities' historical experiences of cancer. When they're saying there's no data and they're being told there's no data, I started looking into it as somebody who works in a health studies program and teaches about these things, and they weren't wrong. There wasn't that data. And as I found, it's not a question of there not being the data, but that it's not accessible and it's not being sort of worked through and analyzed on a local level. And I'll talk more about that in a minute. But just to give you a sense of where this project's coming from, we ended up calling it the People's Cancer Incident Screening Tool. And it's basically an effort to kind of create another dot in this picture where we have the experiential evidence. We have so many cases of a rare type of cancer in our children's school district, and we can make a reasonable judgment that that's not, quote unquote, normal. We also know, based on, let's say, the Pittsburgh studies, that if you live within a mile of a fracking well, children have a 5 to 7 times higher incidence rate of lymphoma. So we have that kind of scientific, gold standard scientific evidence. And so what PCIS is trying to do is to sort of connect that to a community's experience and to say, for instance, we have 4 times or roughly that, the average rate for the state of Pennsylvania for pediatric Hodgkin's lymphoma, okay? So I just want to very quickly, I don't want to spend too much time on this, but I just want to quickly talk about the fact that we have, in the process of doing this, and I think the reason why this data doesn't exist, and I want to talk a little bit about why this data isn't available at the local level, is that we live in a regime that I would call a kind of fossilized regime in terms of how we have our understandings of cancer. It's fossilized in the sense that I would argue it's kind of heavily sedimented and institutionalized ways of doing cancer studies, of the methods that we use. And I would argue that aspects of this really powerfully serve the interests of the fossil fuel industry. Just very quickly, one of the most prominent ways that that's the case in public discourse is the understanding of the individual as the patient and the root cause. So we have a case of cancer in someone, the physician is more than likely to really heavily focus on that person's genetic inheritance, on their quote unquote lifestyle choices, right? Are they exercising? What are they eating? And then just the idea that cancer is a result of bad luck. We cannot control it at all. Another aspect of this, though, that I want to just highlight is this idea of a cancer cluster. And the cancer cluster makes a number of key operative assumptions that I just want to flag as things that we can very reasonably question based on the actual context within which we live. One thing is that the cancer cluster assumes the idea that outside of the cluster, cancer is appearing in a kind of random distribution spatially, that that's the norm, and then the normal is that there's some kind of a clustering. We know from ecological studies of cancer, of a whole varieties of cancer, that no cancer has an entirely random distribution or equal distribution spatially, so that really doesn't hold as an operative assumption. The other thing the cancer cluster relies a lot on, and its focus is on, is trying to establish a connection between some kind of atypical or unusual singular environmental exposure and a preponderance of cases of cancer. But we all know that we don't live in a world of singular exposures. We live in a world of multiple exposures based on what we're inhaling, what we're absorbing, what we're ingesting. Those exposures can also change over the course of our life. So trying to isolate singular exposures becomes it's almost a fool's errand in the sense that in the real world, outside of a laboratory, it's extremely hard to do that. Now, we have very sophisticated epidemiological studies that do manage to do that, but I would say it's an extraordinarily hard bar to reach in the real messy world in which we live. And it doesn't reflect our world of, we don't live in a world of singular exposures. We also have this idea of fixed and bounded population clusters in space and time. And I would just highlight, again, none of us live in a cluster. We may have our place of residence, but people are working elsewhere. People travel all over for different times of the year. Kids might go to school in one place, but they're doing all of their sports practices in another place. So in short, we don't live in a fixed, bounded world. We live in a world where we have a lot of mobility, especially not least because of the preponderance of individual gas-powered vehicles that move us all around. We also have this idea often of very fixed and unchanging topographies and meteorological patterns, but wind patterns can be seasonal. You can get inversions, for instance, in the cold winter months where the pollution stays really close to the ground. We also have, upstreams and downstreams, and so there's a lot of factors that go into shaping also the dispersion of pollutants in ways that don't fit a neat, bounded cancer cluster approach. And again, just to summarize, this idea of an exceptional and clearly delineated cluster doesn't really reflect the norm. Just to give you a sense, though, of the extent to which this is really institutionalized, the American Cancer Society states that, for the most part, cancer cases in the United States are spread randomly across the country. For most well-documented cancer clusters that have been found to be caused by a shared exposure, the exposure took place in the workplace rather than in the communities where people lived. Even if the number of cases in an area is higher than expected, it still might not be caused by a single factor or exposure. So again, it's really just giving this idea that you can't know or make sense of cancer at a community level. The last thing I just want to quickly cover is statistical significance. And for me, and the development of the PIECES tool, this has been a big one. I would argue that we have made statistical significance a god that we all worship. We run the numbers of cancer cases and population through a set of mathematical tests. We have our variables of interest, and we have our confounding variables, almost like in a laboratory setting. We deem that there must be a 95% certainty threshold to be able to say, okay, this is statistically significant. And what we have is a situation where math and formulas, completely abstracted from context in the world in which we live, are telling us what's significant. And they're doing so in an extremely rigid way that don't actually allow for a lot of the realities in which we live. And I would argue also set a bar that's very, very high and makes it very hard to assess. So in short, all put together, we have a situation where we wind up invalidating communities, especially in sacrifice zones. This idea there's no community data, there's an insufficient population size, and this is especially an issue in Pennsylvania because the smallest towns and boroughs, you can never have a population size that's large enough that it could you could ever run these statistical tests and get a statistically significant finding. So the idea is, well, it can't be done. And it's no small part of the reason it hasn't been done. It's not possible. We have to suppress the values. And so what PIECES has really done is said, what happens if we just set that aside for a minute? Okay, we're just going to reconstruct over a 20-year period of time, what do the crude cancer rates look like in towns, municipalities, and boroughs in Pennsylvania? We're also going to, as Kathy was pointing out, these exposures affect all the organ systems. We're not going to make a priori assumptions about which types of cancer. We're going to do all 23 of the leading types of cancer. We're going to run it for the total population, but also, as Cassie was saying, there are differences by gender, so we're going to do it by gender and by age. And then we're going to make this data as rapidly as we can, freely and publicly accessible to communities so that they have the information in their hands. So I just want to very quickly, I know I'm coming out of time, run through what some of these maps look like, and then I'm happy to, we'll go through them later after the panel or in the Q&A. I just wanted to show this map first. This is the 20-year history of laryngeal cancer. What it shows with these different signals is the percent that cancer in a given township, municipality, or borough is higher than the Pennsylvania average over a 20-year period of time. The sort of darker the color orange and red, the higher the incidence rate. I do think of these as a signal as opposed to an absolute incidence rate because we are dealing with things that would not pass statistical muster, quite frankly. So it's better to think of it as we're getting a signal there that in these towns and boroughs there's an elevation. And what I would just highlight is this is for laryngeal cancer. It is the rarest type of cancer that we look at in adults. And this is the pattern for Delaware County along the Delaware River. Is this a random pattern? I don't think so, right? And I think we can make a reasonable judgment that that's not a random pattern, that there is a clear cluster of contiguous signals along the Delaware riverfront where we have the oil and gas refineries, the incinerators, in Tinicum at the right side, we have the airport, we have a lot of factories, et cetera. Okay, so the idea with this tool is that, again, we can look at these signals and this what has actually happened historically, and we can make judgments, and especially where we see contiguous clusters of signals. So what about in children? It's even harder in some ways in children because the population you're dealing with is even smaller, and the cancers in kids are always rare. But this is, as Kathy was showing us, leukemias and lymphomas popped up a lot on her slide. And this is what pediatric leukemia looks like in Delaware County, the 20-year history. And what I would just say here is that, again, you can see that there's a contiguous cluster of signals right along the Delaware riverfront there. Also that the signals that extend over here, they do get weaker, as we, generally speaking, as we move kind of out west. This is where we have an oil refinery that from Delta Airlines which releases a lot of benzene and other things, where we're clearly getting strong signals. But this is the Mariner East pipeline that's bringing the fracked gas and other things down through to this refinery. All these purple lines represent different pipelines, so it's bringing in a lot of the fossil fuel products. So we need to think about the fact that there is an infrastructure. Not only does the wind blow, right, from these communities westward across the county, but we have this whole infrastructure under our feet and in our homes, frankly, of gas. So I'm just going to quickly then go through the rest of the slides. This is brain and nervous system cancer. Again, I think you can see that there's a lot of cancer that's elevated over the PA average in Delaware County as a county that has a lot of oil and gas refining and all of these pipelines coming through. I can walk us through some of these points a little bit more too, but there's also a big storage tank farm. There are youth sports fields situated right next to that big oil refinery, and there are kids that play there 3 or 4 times a week throughout their entire childhood, but might live in the western part of the state. So I'm hoping that these maps paint a picture that also allow people who are residents in these communities to be able to provide interpretations other than statistically significant or not significant, like a null finding or a positive finding, that there are other ways, more nuanced ways that we can read and interpret these different cancer signals in communities that people who actually live there can help us to explain and understand. Hodgkin's lymphoma, again, we're seeing a lot of lymphoma, including in the area where there's a large oil tank farm in Aston. And non-Hodgkin's lymphoma, another one where a good amount of the county is lighting up, is above the state average. So just lastly, we'll do Washington County. This is what the map for leukemia looks like. And you can see that there are a lot of different towns and boroughs that are elevated. And I would especially draw your attention to this central belt in the middle. Mount Pleasant, my understanding is that's where the first well was fracked, and a lot of the longest standing fracking is happening here. With any cancer, it takes time to develop, and I think the development obviously in Washington County is ongoing, and so some areas may have a longer history and legacy of it, but that's what leukemia looks like. And if you just pay attention to the central belt, there's Hodgkin lymphoma, there's non-Hodgkin lymphoma. And there we have brain and nervous system cancer. We're getting a bit of a different pattern. But you can see a lot of communities are empirically experiencing an elevation in their rates of cancer over that Pennsylvania state average. And the last cluster I would just highlight, because it really comes up clearly, we have these 3 contiguous signals that I would argue are very unlikely to be due to chance for pediatric melanoma up in the northern part of the county. Just very quickly then to wrap up, also, I know that there's a lot of concern about Ewing sarcoma, and this chart gives us the rate of cancers in Washington County versus the Pennsylvania average. You can see that indeed, even across the whole county, we see an elevation for leukemias. We actually don't for lymphomas, although it's clearly is very elevated in certain areas. We do see it for brain and central nervous system cancers. But for soft tissue and extraosseous sarcomas, which is not one of those 23 leading types of cancer, so we can't do it at that more local level, but we can at least see how it compares on the county-wide level, it's even higher. And Ewing sarcoma is interesting because it can arise in the bone or in the soft tissues around the bone. And so it actually gets segregated into two different buckets in the cancer registry statistics and in the Department of Health statistics. So one of the things I'm interested in is maybe forming connections and collaborations with people who might be interested in digging into that problem a little more. So just lastly, I want to thank everyone because this is a lot of work, a lot of labor to put this together through, we've now done hundreds and hundreds of towns. This is our team, Sevilla Kent, who's been our lead research assistant starting all the way last summer. The names in bold are people who directly contributed to the work for Delaware County and for Washington County, and the names with the stars are here. They're at this table right in the middle. And I would be totally remiss not to especially thank Physicians for Social Responsibility, Antonia, because without it, her support and support of PSR, this work could never have happened. So thank you.
Thank you so much, Lauren. I'm sure we could take a whole day just to dive into that, all of that really fantastic information. So thank you for sharing that with us. I am now going to bring up our final speaker, Dani Wilson, MSW. She's the Executive Director of the Cancer and Environment Network of Southwestern Pennsylvania. Dani's background is in social work, but she also has extensive experience in the field of public health, including work with Cancer Bridges, Cancer-Free Economy, and the Environmental Health Work Group within the Pennsylvania Cancer Coalition. So without further ado, I will hand it off to Dani.
See if I can find this green button. Okay. Great. Good morning. Hi, everybody. Thank you, Alison, and thank you both. That was really wonderful information. As Alison said, my name is Dani. I'm with the Cancer and Environment Network of Southwest PA. And before this role, I was Executive Director of Cancer Bridges, a cancer support center. And I regularly saw parents in that role whose lives had just been shattered by a childhood cancer diagnosis. And they always had the same question: how did this happen? Not necessarily why, although that does come up, but how did this happen? And answering that question is what drives our mission at the Cancer and Environment Network, to equip people with the knowledge and tools needed to take action before a diagnosis happens. And our vision is simple but bold. We envision a future where the people of Southwest PA are no longer exposed to toxic chemicals that contribute to cancer. So we came together in 2019 because we know that progress in cancer prevention is not shared equally. There are fewer resources, generally speaking, across the nation for preventing cancer from environmental carcinogens. The network now has over 50 participating organizations. We are grounded in science and systems thinking, and we use a 3-tiered model, you can see here, to translate shared information into regional impact. So we co-learn together. We share research, emerging trends, and lived experiences through our science, government, and healing and justice hubs. We amplify initiatives of participating organizations so that others in the network and beyond can hear their voices and align their activities. And we co-create together when we launch agile action pods designed to fill critical gaps and generate high impact results. So looking at these SEER trends from 1975 to 2022, you can see, while medical treatments continue to improve and survivorship is going up, which is really fantastic, at the same time, incidence, new cases of cancer continue to rise. So this shows you that the incidence of kidney, breast, thyroid, non-Hodgkin lymphoma, and testicular cancer continue to climb steadily. These are all cancers with environmental links that have been documented. And perhaps most alarming is the data on our children. Since 1975, the incidence rate for cancer sites combined in females under 20 has shown a consistent upward trend. In Allegheny County, we see elevated standardized incidence ratios for many cancers that have known environmental triggers. Thyroid cancer is 30% higher than the national average for men. Bladder cancer is 28% higher for women. These adult elevations are warning bells. Our children are living in the environment, the same environment where these spikes in adults are already happening. So we can no longer ignore the geography of illness. Research that's been mentioned already by the Pennsylvania Department of Health and University of Pittsburgh confirmed what residents have long suspected. Children living near fracking wells face higher risk for cancer, asthma, and low birth weights. And why are they at higher risk? Because children are not just small adults, they are bodies with a dynamic state of growth. As this table from Johns Hopkins shows, a premature infant breathes 40 to 70 times per minute, compared to just 12 to 18 times per minute for adults. Pound for pound, children inhale more air and drink more water than we do, meaning they receive a higher dose of every environmental toxicant in their vicinity. Their development windows from the fetal stage through adolescence means that exposure to even small amounts of toxics can have lifelong consequences. They also play closer to the ground, increasing their risk of inhaling or ingesting contaminated dirt or dust. Nearly 24 carcinogens have been found in the air near fracking operations, including benzene, formaldehyde, and radon. So we don't need more data to know there's a problem. The research is pretty clear. Children living near these facilities have increased odds of developing acute lymphoblastic leukemia. The risk is highest for those within 2 kilometers of a well during the perinatal period, but as my colleagues mentioned, it extends as far as six miles out. And we see consistent associations between proximity to these sites and worsening respiratory health. So as a public health network, we believe that only calling for more studies is not an effective solution. Our 2025 annual research review, which we released yesterday, proves the evidence is already overwhelming. We don't need another decade of data in order to protect children. We know enough to act now. So what does that mean to act now? What can we do today? So many folks in this room are doing quite a bit of this, but I'm going to review a few things that we can do. And the first is to turn off the tap. We have to stop the problem at its source. This means moving toward a bio-based renewable economy that doesn't rely on fossil fuels for energy or the chemical feedstocks used in pharmaceuticals and plastics. Until that transition is complete, we need transparency. Families have a right to know every chemical that is being pumped in the ground near their homes. We need the state to not just set rules, but to have the authority to enforce them. And then there's setback distances and cumulative impact. A single well is one thing, but our children live in a cumulative environment. We need to increase the physical distance between these industrial sites and our schools and sports facilities. We must regulate based on the total chemical burden a community carries, not one permit at a time. And testing for radon. So most of you know Pennsylvania has more naturally occurring radon than most states in the country. Fracking creates new pathways in the geology for this radioactive gas to rise into homes and to schools. And there are currently 2 bipartisan bills moving through Harrisburg that would finally mandate radon testing and mitigation, with results reported directly to parents. We know children are uniquely vulnerable because they breathe faster and spend 180 days a year in these buildings. And you can join us next week. So the network is having our all members meeting. That QR code will allow you to go where you can register. And together we'll be selecting and launching The projects that our network and our collaborative partners will be working on over the next few months. So I hope to see you there. Thank you. They should be on.
They turned them on. Testing.
Yeah. If you have questions, I think there's somebody going around to collect cards, but can you hear me? That's great. Okay, we do have a couple minutes for Q&A. So thank you in advance for anybody sharing questions. I can tell you right now, we're not going to be able to get to all of them. So please do seek out these fantastic panelists during one of the upcoming breaks if you would like to talk any more about their work. But to start off, I've got a question for Kathy. So why aren't there regulations around new oil and gas extraction techniques the way we have around new pharmaceuticals and medical devices? What's going on with that?
This is a source of great pain to me. As a physician, I can't use a medicine until it's gone through rigorous testing. And that's supposed to be something to help people. So maybe the oil and gas industry says that oil and gas is to help people, but there's very little regulation, primarily just at local levels with zoning to prevent a new technology like this from coming in. I think it's a historical oversight. Medicine was regulated starting in the 1900s because people saw that people could be made ill by medicines and peddlers of various potions going around. And they said, this is really a problem. We should have some science that goes into this, and people should have to prove that what they're offering to the public is going to help more than it's going to hurt. I think we should have exactly the same thing for the introduction of other new technologies, especially when they're going to affect whole communities. We haven't had it. That part of the reason New York State has a ban on fracking is because we had less oil and gas industry presence, and we found out what was going on in the western states and stopped the fracking industry from coming in. Pennsylvania was already established, and so we have to roll back. But I think similar types of approaches could be used. I didn't mention, but I should have, that one of the ways that I know that fracking causes these harms, besides the wonderful research of my colleagues, is that the oil and gas industry, when challenged by potential lawsuits, by people who've been injured, often will settle and even buy out the people who are living there. That is because they don't want to have to try to defend it and say that they didn't do this. We don't have those good technologies. It's starting to happen in relationship to forever chemicals as well. And basically we shouldn't have, multiple exposures, like people will sometimes say. We should get rid of all those harmful exposures. And starting with this one is a good idea.
Great. Thanks, Kathy. I'm going to switch gears a little bit. So for the people who are saying we don't have the data, we don't have enough data to act, we obviously know that's not true, but that in some cases there are limitations on access to existing data. So Lauren, I'm going to ask you, how can we ensure that data from PCIST gets interpreted by lawmakers as valid, given that the data isn't technically statistically significant in all cases? So when making these kinds of observations, how do we work to standardize this data or account for other random differences? There was a lot in there. So anything you want to take on?
Well, first, I personally believe there needs to be a broader pushback on the standard of statistical significance. I think one can look at a map and see 9, 10, 12 contiguous clusters. That is not random chance. I also think it's about piecing together different types of data. I'm not a big fan of strict hierarchies of evidence, and I think when you have a picture that looks like that and communities in those areas that are painted orange and red all saying that they're experiencing elevated rates of cancer, and you have the science establishing the connections, that is enough to act. And I think that one of the benefits or the value of PCIST is that it can really show the data represents what actually happened in a community. So on that level, whether you want to say, oh, okay, this is only, 92% significant or even 75% chance of a significance, it's what actually happened. It's what they experienced. And lastly, I do think there are approaches which we have been working on where you can build together a region where you can then rise to a level where the numbers approach or even formally qualify as statistically significant. So that is another method that can be used. So for instance, on the Delaware River front, we have grouped together all of the communities that can very meaningfully be grouped together because of their shared cumulative pollution exposures, and then run the numbers for the community as a whole. And I think that's another strategy that can be used. But I just think that the doubt will always be cast. No matter how much, it seems quite apparent, no matter how much evidence, no matter how statistically valid, there will always be pushback from powerful fossil fuel industry. And so we need to use everything we have at our disposal to paint different pictures and show that in the real valid lived experience of people, and that can be demonstrated qualitatively and statistically and empirically, shows otherwise, that there really are these harms.
Great, thank you.
Could I add on to that? We also should shift the burden of proof. That's a legal term. I'm not a lawyer, but I have some legal training. And burden of proof means who has to show what. So here we are trying to prove that this industry harms us with all these various approaches. They should have to prove their industry is safe. If they're not doing something that is safe, they shouldn't be doing it. That's the basis of trying to have regulation and some assessment up front. And I say that not because we can get that easily, but that we should always be ready to push back and say, we've got a lot of evidence to show there's harm. Where's your evidence that this is safe? I don't think they can produce anywhere near that same amount of evidence.
Yeah. I have a follow-up question to everything that's been said, but I want to make sure, since we've gotten several questions on this, I want to make sure we get time to answer this. Dani, what are the radon bills, the two radon bills that were mentioned?
Oh, the numbers for them?
Yes.
I do have them. I'm forgetting them in this moment.
If you want to take a look, I can ask this next question.
Yes, great.
So we're talking about engagement. We're talking about using data in different ways, and especially trying to counter this almost lack of empathy for people who are being impacted. So what is a good way to encourage greater empathy for the people who are being impacted from people who are not being impacted, particularly decision makers? Are there certain messages, certain audiences, certain approaches that are going to be particularly useful in this effort?
Okay, so
anybody.
Well, okay. Well, first I'll say it's House Bill 289 and Senate Bill 760. So they're both bipartisan. Obviously, it's bicameral. And if you live in Pennsylvania, you could contact your state legislators and ask them to join it as a sponsor. There's a lot of sponsors. They're both in committee right now as well. So there's some real movement there. So thank you for asking for more details. And then the question is how to increase empathy?
Yeah.
Oh. Okay. I am a social worker. This is something I should, here are the 5 ways to do this. Wow, does anybody have something off the top of their head?
Go quickly.
Sure.
I think that connecting for instance, like the signals with lived stories is so important. I think it's the stories that people have that is the most powerful, but that they do often face this invalidation and, oh, that's anecdotal, or that's just you toss coins up in the air and it falls down randomly and that's what you get. So I think hopefully being able to piece together like really solid science with evidence showing what's actually happened in communities with those human stories can build empathy. But the other thing I would say that in doing PSIST, wind blows, water flows, pipelines run everywhere, gas is pumped in all of our homes, that there are elevated rates. I mean, this is just a small piece of types of pediatric cancer. There are other types of pediatric cancer, but there are also a whole range of cancers in adults. And I think a lot of people who thought they lived in communities where they were somehow in a little bubble because it's beautiful and they don't smell anything and they don't see anything, are surprised when you show them not only what their neighbors are going through, but what they themselves are going through in their communities. And most people in most communities, certainly around wider Philly, I think have an experience of a lot of cancer in their families and in their neighborhoods and in their communities. And certainly, as Dani was saying, like certain types of cancer are clearly on the rise, and there's no really disputing those patterns. And so I think that that's another, the idea that we're all interconnected is something that maybe we can push a little harder on, that sense of people take a kind of NIMBY attitude, well, it's not, as long as it's not in my backyard, it's okay. Well, it's not okay. It's still going to affect you and your family.
I'd like to add to that it takes time, right? So if you're going to have conversations with people and you're hoping that there's going to be some empathy building exercise, it won't be quick. And, you know, we are conditioned, we've been conditioned for decades to be antagonistic, and there's a place for that, to call people out, there's a place for that, but the practice of calling in is a completely different skill that requires you to sit next to somebody, maybe for hours, and have these conversations, like to come at it with your own empathy on what they're thinking, what they've experienced, why they're not seeing this. There's so many barriers for people to cross, especially if they're deeply entrenched in the oil and gas industry, to kind of look at what's actually happening outside of their house and their neighborhood. So be patient.
Yeah.
Yeah.
Last words, Kathy? We're
Yeah.
pretty much out of time. So.
Yeah, I would just say patience and persistence. And whatever knowledge you have, bring it. It doesn't have to be the thing that will generate empathy. It can be any form of knowledge, because we love the things we know. So we have to get people to know this well enough to be motivated to do something about it and know that they can do something about it.
Great.
And I just have to thank the people who were very badly impacted here in Pennsylvania, who came to New York as we were trying to bring in laws to ban fracking, and told their personal stories. It was hugely, hugely helpful. And I worried at the time that we were imposing on people who were already sick, but they feel good about having contributed to protecting another community. So don't hesitate to ask your neighbors who are impacted to join in helping to do something about this.
Yeah, that's great. Thank you so much. And yeah, as we've seen this morning, it takes time. It takes a combination of different types of research, different perspectives, different approaches for different audiences to make progress and to protect people from shale gas pollution, which is why I am really happy to see such a diverse group in front of us today. And that is unfortunately all the time we have for this panel, but we've got a fantastic slate of panelists coming up on stage in just a minute. So I want to once again thank our hosts, thank our panelists, thank you all for the great work that you do every day, and looking forward to hearing more about everybody's work and perspectives throughout the day. Thank you.
Thank you.
Okay, our next panel is Exposing Sources of Industry-Related Health Impacts, and that will be Gary Alison, Kimberly Terrell, and moderated by Aaron Berchowski. I forgot to mention that there are a number of tables where a number of groups are tabling, so I encourage you to go and see what they have to say and maybe sign up and join a group.
Okay. Okay. So we're scheduled to start the session at 10:25. So please take a few minutes for a biological break or a little break, and we will start up at 10:25. Hello, Kim.
Hey, good morning.
I'm not sure how this is all going to work, but we'll get going in just a few minutes, and I'll do an introduction, bring Gary on, and then get to you as well.
That sounds good. And can you hear me okay?
Yeah, we can hear you.
Awesome.
They have great technical people here.